Welcome to our series of healthcare scene interviews where we sit down with top leaders in healthcare IT. I'm John Lynn, the founder of healthcarescene.com. I'm happy to host this amazing group of direct project experts. And that's our topic for today is direct project and the impact it's having on healthcare. Before we begin, I just want to remind those watching live that we'll talk for about 30 to 40 minutes and then we'll open it up for questions from the audience. Also, for those new to Blab, which is hosting this video chat, is if you'd like what someone's saying, all you have to do is click on their face and give them some props, as they call them. And you can see, that's kind of the habit is give people props if you like what they're saying, or maybe if you just like them alone. Also, on the left side of the screen, there's an option to share this Blab on Twitter and Facebook. We appreciate if you share that as well. And finally, if you have any questions, you can put /Q and then space and then your question, and that will add it to the question bucket on the left side. So feel free to do that, and we'll get to them during the chat if possible, or at least at the end, we'll include all those questions. All right, well, I think that's all the housekeeping work. So let's get started with some short intros from our esteemed panelists. Let's start first with Julie Maas, Lady in Beauty first, I guess. Julie is the founder and CEO of EMR Direct. Tell us about yourself, Julie.
So I run EMR Direct. We provide a direct service to about 100 EHR vendors through our easy to integrate API that's available for .NET, PHP, Ruby on Rails, Java, and other common application frameworks. I also evangelize about Direct quite a bit because I believe it solves a lot of expensive problems and that improves care for everyone, everywhere, potentially.
Excellent. And hopefully we'll dive into that today and help people understand more how it can help. Next up, Greg Meyer. He's a distinguished engineer at Cerner. Tell us what you do, Greg.
Yeah, so I'm responsible at Cerner for the maintenance and the architecture of the Cerner Direct HISP. That's kind of my day job. I actually only spend maybe about 20% of that. Like Julie, I spend a lot of time evangelizing Direct out of the community. I currently maintain the Java reference implementation for ONC, as well as I actually wrote the Direct project reference implementation in Java. So I still continue to maintain that. I also spend a lot of time in Direct Trust. I currently maintain their network for Trust Anchors, as well as their Trust Anchor bundle, and pretty much anything with Direct, I got my hands in at some point.
So you live, eat, breathe, and sleep Direct.
I do.
That's what we like. Thanks, Greg. Welcome. And finally, Mark Hefner, CEO of Infina Connect. Welcome, Mark. Tell us about yourself.
Thank you very much. I've been focused on healthcare in a variety of different environments, hospital, post-acute, ambulatory for about the past 14 or 15 years, and couldn't be more excited about where we are with the adoption of really value-based care as a driver, direct messaging and other technological innovations that are making a difference. I lead Infina Connect Healthcare Systems. We actually are focused on referral coordination. It's used really as a core element of population health. We ended up with a great opportunity to kind of have a front row seat to what's happening with the evolution of direct messaging, and excited to talk about it today.
Excellent. Well, thanks to each of you. I love how you each bring a very different perspective to what's happening with Direct. So hopefully we'll dive into that today. Maybe to start off, Julie, how about for those not familiar with Direct Project, could you give a kind of a short overview description of Direct?
Sure. So Direct is secure, trusted email for healthcare. Direct messages are both digitally signed and encrypted to protect the confidentiality and integrity of the content. Direct uses existing building blocks like regular email and secure MIME, and digital certificates to accomplish this, with some additional unique innovations like automated key discovery. Direct addresses look just like email addresses because basically they are, but both sender and recipient need to speak direct, or in other words, they need to follow the Direct protocol in order to exchange with each other. It's an open standard, and since it has email at its core, Direct can handle any data payload or attachment that you might send by email today. Because it's an open standard, a Direct address is a reusable endpoint. Direct can be much more economical than the previous model of one-off custom point-to-point connections between healthcare partners. And most noteworthy, Direct reached its millionth endpoint this year. So we're really excited about the breadth of the network at this point.
Interesting. So 1 million endpoints, that's quite a milestone. So let's talk a little bit more about practically, how is Direct being used in healthcare? Where are we seeing it? Mark, you want to share what you're seeing?
Sure. Well, we've seen most of the usage really around referrals and transitions of care. Meaningful use is kind of that initial driver, driving that. But now we also see chronic care management coming on board as well. The challenge has been kind of as the early adopters that providers can't use it consistently because not enough recipients are either active or known to them. As Julie said, we've hit 1 million endpoints, but in some cases they don't even know who around them may be capable of it. So the challenge is, how do you get past some of that? And in fact, how do you get past, fax as really the dominant form of communication across healthcare? We have a kind of an interesting perspective in the sense that we've got a very diverse, large-scale deployment of a referral coordination solution in Raleigh. It might be the largest in the country today, but we've got people of all types, post-acutes, full hospital health systems, folks on certified records, folks on not. And they've been one of our drivers for looking at kind of how do we solve some of the roadblocks. We kind of look at the opportunity for Direct, and really one of the greatest values of it is as a standards-based way in and out of EHRs, with CCD as the payload, right? And that turns out to be a breakthrough that we wanted to take advantage of. So we've incorporated that into a broader coordination, referral coordination, and communication platform. And that's actually opened up usage. We've now got providers using it to a much greater extent because we've also enabled them to deliver really to any recipient. And that's kind of a breakthrough in the sense of it isn't just limited to those direct message recipients that they're addressed for. We've actually made it available electronically to any recipient. So we're really on this journey, not only to solve the workflow problem, but ultimately we'd love to see the potential for Direct to displace fax and paper altogether. And we think that there's great potential to do that.
And is that what it's kind of limited to today, is replacing the fax, or is that kind of too narrow of a description of what Direct's able to accomplish?
Well, much more capable than fax, because now you've really got discrete data coming across. CCD documents, we see eyes light up when folks first begin to see the potential of what's available as a communication mechanism and the fact that they can incorporate it into their respective records. So no, it isn't just a displacement of fax, but quite frankly, fax is so prevalent, and we're one of the few industries where that's the case, that enabling universal electronic communications, we think, is kind of that bridge to get a much more effective outcome.
So you start by connecting the endpoints, and then we can do more. You have a unique perspective at Cerner, Greg. How are you seeing it being used, and where are you seeing it, really impacting healthcare?
So everything you just said is pretty much along the lines of what we've experienced as well, where mainly transitions of care is the main use case that we see out there, but it's definitely not limited to that. And I'll go into a lot more of that later because I've got a lot to say on the use cases of it. We see it in referrals. That's probably the biggest second use case that we have out there. There's general report distribution and PDFs. That's kind of replace the fax. There's also some other non-meaningful use care coordination that we see. Some examples like coordinating with long-term care facilities. We've seen other use cases come out, such as admission notifications, so basically ADT notifications via Direct to the primary care physicians. Not so much, but still trying to pick up, and I know we're going to talk about this later, the view, download, transmit. This is something I actually personally use out inside of my own portal. We have a clinic here at Cerner. Whenever I leave, I always go in there and I do a transmit of all of my data via Direct to an application that I run out there. I'm starting to see a lot of other kind of upcoming things in the industry. The feds are going to get into this. I've seen some other potential use cases around claims validation. You'll see, from different organizations. I've also seen some other ones in there for clinical research. I've been in a lot of proof of concept conversations on that. We even saw one precision medicine kind of proof of concept this last summer that was using Direct to push the information out of the EHRs using Portal or the EHRs directly back into some type of research clinic.
Interesting. So that's a wide range of opportunities. Anything to add to that, Julie, or maybe even let's take it a step further. What difference are these things making in healthcare? And what's the volume that's actually happening today? I mean, is this something people are just talking about? Are they doing it? I mean, there's a million endpoints, but how much is really being shared? Like, is it impacting? What's your view?
I think it is, and certainly the ability to know that as a patient you have the right to get access to your data, and as patients begin to be provisioned much more so for direct, and we're going to see that this year, I think, in much larger numbers than we have ever before. There's an opportunity really to reach not just any provider, but any person, and for people to assemble their own records and universal records for themselves as patients for the first time.
So, I mean, let's go there now. Greg brought it up and Julie brought it up as well. I think many people look at direct initially. I mean, I probably am at fault for this as much as anyone. I think Julie opened my eyes when she said, I'm sending you a direct message, that we sometimes think, oh, direct should just be doctor to doctor, but it's also available doctor to patient. Are we seeing a lot of that? Who's implementing it? What are you guys seeing?
I'll start out at some of that. I mean, with meaningful use too, the view, download, transmit specifies that you have to have those capabilities. You don't actually have to do it or do all three of them. So you could be doing just the view portion of it. But those that have implemented the full view, download, transmit, I mean, I think we're going to start seeing more use of that. I think it's just an educational piece at this point. A lot of people actually have access to this capability. They just don't know it yet. So I think it's just a matter of time before starting to see some of those use cases of provider to patient become a lot more prevalent and trying to create kind of more meaningful types of use cases. I mean, right now I can consolidate all my data. Okay, that's great. But for a lot of folks that have other kind of mainstream conditions, I'm not sure how much that's going to help them out. So I think trying to use the capability as a transport mechanism to get my data and potentially move it to other places is going to have a lot more effect as opposed to just consolidating it in one spot.
Right. There's also opportunity for simple. Oh, I'm sorry. Go ahead, Mark.
Good. That's okay, Julie. Go ahead. I'll chime in after you.
Simple things like patient to provider communication that are, some applications have used direct to meet the secure messaging measure, and that will continue, I think, as much as direct is a common way to get information out of an EHR. It's also, as patients are provisioned for direct, a common way that I can communicate with my doctor or with my proxy or many other people in the care continuum.
Yeah, we think this ties in perfectly to what you might call the consumerization of healthcare, but giving patients access to their record, first of all, rather than being kind of forced to access a portal, it now becomes something that I want to do, to get notes from a recent visit, to understand what's going on, and if necessary, to be in control of that information. If I end up being seen at a different provider, I'm out of town, something happens, I've got access as well to provide a very recent, perhaps the latest, version of my clinical record to a provider that I'm seeing. So we're excited about it. We think that the blue button capability, as was stated before, it's like it's there, but it's not really being widely used. We think the more that's accessible, the more interesting it will be to include both patients and their authorized, caregivers, family members, et cetera, within that communication loop.
And we lost John.
But that doesn't mean we can't keep going. So, we'd love to hear, maybe your guys' thoughts. I mean, folks have struggled. Everybody's trying to get to, 10% meaningful use. We looked at it in our particular case and, we attacked that problem. But, here it is. There's a mechanism to do it. But yet, quick comments maybe on why folks are struggling to hit, the 10% metric and expecting that to go to 50%, with meaningful use 3.
We got him back.
Yeah. So it's interesting. It looks like it's a bit of a chicken and egg problem that, you need to know that your doctor has that available in order for you to use it. And there's a lot of people who don't want to do interesting things with that data because it's not quite available. So, I mean, I think, we'll see that evolution over time. But, let's go back to the kind of the doctor side of things. That's where I think most healthcare scene readers are interested. So if I'm a doctor, why should I use direct as opposed to just continuing with fax, right? I mean, what's the compelling incentive for me? How does that impact my life? How does it impact my patient's life? Mark, you want to start since you're working with so many doctors?
Well, yeah, a few quick thoughts. I mean, first of all, my economic and clinical outcomes are actually now much more predicated on my ability to do this, right? I may have meaningful use requirements to hit. We were just talking about, hitting the 10% requirement. I may be managing patients under CMS's chronic care management program, in which I'm required to do electronic transitions of care. I may be part of an ACO or a group that's beginning to manage patient populations and need to have visibility to what's happening with my patients downstream, ensure that transitions of care are coordinated, that referrals that are needed happen. So you actually are talking about ultimately doing the right thing for the patient, taking better care of them, reducing their overall incidence of unnecessary, healthcare episodes, right? Unavoidable hospitalization, just to pick one example, a coordinated transition of care that precludes, problems from occurring, to pick another example. That's why we think that this becomes compelling. But as in all cases, even when it's the right thing to do, sometimes it also takes economic incentive. And that's now coming from more than one direction, really focused, if you might think about it as focused on primary care, who's originating a lot of the transitions of care. It also matters materially to hospitals as they manage patients at discharge with all of the readmissions, requirements associated with that. So we think the economic really helps people adopt, if you will, and it just gives them another reason to.
Interesting. Does it make a doctor more efficient? What do you think, Greg or Julie?
Definitely. Compared to having an analog fax that may or may not be readable, that may not come through reliably with acknowledgments, you have a digital record that can be preserved and analyzed along with other historical data, combined from other points of care and consolidated to really make a complete picture of a patient's history together in one place. It's really a paradigm shift compared to what we have access to right now. The patient record is not at disparate points of care, but it can be consolidated to where it's needed.
Yeah, and I'll kind of add a little bit on top of that, sort of the an underlying financial aspect of this, maybe not so much a clinical care thing, but if you're somebody like a small practice, a lot of these big organizations out there that folks that may refer to, I mean, they're going to have these capabilities. That's what MU2 requires them to have at a very basic level. So you do have this ability to create this secure and electronic way to go do your exchange of information. So in essence, it represents a much easier way to get your information to and from these bigger organizations. I can only imagine that's got to be good for business.
So if this is an easier way, what's really holding direct project back? I mean, I've heard certain complaints about that there's no directory, which I think Mark, partially addressed before. But what's really holding direct project back from being implemented more widespread? If it's more efficient, it's better for the quality of care. It's obviously certain financial requirements, meaningful use, et cetera.
I'm going to start on that one and take you, because there's many aspects of that. I'll take you back to the earliest days of this was really around the policy aspect of it. Direct is built around the concept of security and trust. So the security aspect of it is a function of your algorithms, your security protocols. We pretty much got all that hammered out. The trust piece of this is a function of your policy. So in the earliest days of direct, the policy by which folks operated their systems, and this has everything to do with how you authenticate, how you identity proof, how you operate your systems. There was variance all over the place of how that got done. And then before anybody wanted to do exchange with each other, they didn't have a concept of what that common bar should be. So now you had the biggest killer of direct in the earliest terms was this policy variance. So this was probably about 3 years ago. Farzad pulled everybody together into what was called the scalable trust communities, and this was really to go address that policy piece of it, where now you got folks like Direct Trust and other trust communities that are creating a common set of policies. So the policy variance goes away, and you turn a very huge complex issue of having to create all these one-off contracts, negotiations between lawyers, signing of documents into just a one-type document. It's called federation agreements. Is anything new? It's something that came out of the Federate or the Scalable Trust. But you take this geometric scalability problem and you turn it really into a linear problem. So that was the earliest piece of that really blocked everything. So now that we got through that, over the last couple of years, we've actually seen a geometric rate in the terms of adoption, of messages going through. So I wouldn't say it's really being held back at this point. We kind of hit that breakthrough point. The only piece now that would really be holding it back, I think, is a lot of FUD in terms of the education. I see Workflow even mentioned this out there, is the email client essentially the user-facing application. The biggest kind of faux pas about Direct is that Direct is not an application. Direct is not a workflow. I think a lot of people associate it with transitions of care because that's the most used piece of Direct out there. But Direct really is not a workflow. It's really not email. It's a transport mechanism. It's an enabler. The same way that you use TCP/IP and HTTP. If you said, well, TCP or HTTP is too limiting because you only use it inside of the browser, it's actually not. It's used all over the place. A transport mechanism. Folks use it for live streaming, REST protocols. So Direct's the exact same way. It's not an application or workflow. It's an enabler. And I'll get off my verbal diarrhea now.
So Direct is the protocol, but we need people like Mark who are implementing it into a workflow, or Julie who's enabling EHR vendors to use the protocol, and they're helping them enable that workflow. Is that a good way to say it?
I think that's right. I'm just amplifying what Greg said. Direct itself isn't an application. So what we've done is kind of wrap an application around it, but leveraging the strengths of Direct. I mean, this is really, if you want to think about it, it's a breakthrough in being able to do interoperability with EHRs without having to do integration. You can almost term it plug and play type of interoperability. So that's huge. And that actually creates, significant value for everybody involved. But yet, you ask about, barriers, and part of it is, as the early adopters, there isn't necessarily everyone available that you'd like to talk to, right? Other providers, patients, et cetera. And so bridging that gap is kind of what I see as the next accelerator. And by doing that, to allow providers to use a consistent workflow within their offices starts to be kind of the next step. And we're seeing significant volume. We just released a major release about a month or so ago, and already about 24 practices have jumped onto it and beginning to use it to send a much greater volume of direct messages. In some cases, we're having to show them in their EHRs where their direct message interface panel is, and people are using it for the first time and frankly going, wow, this is great, right? This is far better than what we were using in terms of scanned documents, fax, e-fax, and that type of thing.
And you mentioned that you had an onboarding process for people that aren't on Direct, but they can still send direct messages to them. Is that right? And if so, what's the workflow for that?
So really what we've enabled is a delivery mechanism so that a person a group initiating a transition of care, let's just take a primary care physician as an example, but it could be anybody. We're actually saying that on the back end of that, we will either we'll connect at the level of capability of the recipient is a way to think about it. If they've got direct messaging, we'll ultimately end up routing through direct messaging into their inbox so that they can incorporate it into their EHR, but we'll also make it available inside our application. And then for those folks who have neither, we'll actually provide a notification to them via fax and provide them limited access electronically to be able to come in, download, access the information electronically, and accept or acknowledge or reject it.
Interesting. So you're still leveraging the fax system. It's an interesting integration that's kind of required in this half and half world that we're in.
It's the way that people get access to everyone today. And so we chose to leverage that really just as a notification mechanism. The main point is, as you get folks into this, it actually has kind of a viral adoption nature to it. Folks see what's possible. They begin to come in. In our case, they can begin using the application side of this really easily. We have people that ping us to join a network, and literally within an hour or two, they're configured up and using it. And so we tried to make that as easy as possible, kind of getting back to, why has fax been persistent? Well, it's available to everyone, it's secure or considered to be secure, and it's easy to use. So we've embodied those principles, in our approach.
Interesting. Julie, you look like you're interested in talking. I mean, I know you've worked with so many vendors, a lot of EHR vendors, probably any vendor that wants to enable direct. That's the service you provide, right? I mean, what do you see?
Well, that's true. And what we do is we try to make direct messaging something that is almost effortless to enable in an EHR. And what I was going to say in response to Mark is that the examples he's citing and that Greg has mentioned about direct being a platform and not really an email client like we traditionally think about it is to make an analogy, think about the notifications and SMS messages that you get on your phone today. Those messages themselves you understand in their atomic form as a platform, as a building block on your phone. But really, we have thousands of applications now that use SMS and notifications on your phone, and direct is really the same. So it's an underlying protocol that can be leveraged in applications that do very different things, and you won't even realize that direct is a part of them.
Interesting. So there's a question here from Andy Vitale. He says, do users feel that having a direct message in the EHR is a distraction in their workflow? My guess is the answer is probably no, because it comes in similar to a fax, but actually in a much more granular and effective way. Is that true, or what's your take?
I would actually question, first, what's your workflow that you're doing? I mean, if part of your workflow is you've got to get that information out, it all comes down to use cases. If you have that in there, I'd say it's not a distraction. It's actually very, very useful and saves you time. If part of what you have to do as part of a discharge is you have to go print something out, and then you've got to go put it in an envelope. I'm maybe totally making this up, but the fact that I can just click a button that says communicate, type in the location of it, and it automatically ties or generates a discharge summary on top of that. That's 2 button clicks versus create a summary, go print, go walk over, and I just did something in 30 seconds as opposed to something that takes 5 minutes.
Yeah, that's true in the sending, right? But in the consuming, I think that's one of the beauties of direct is it kind of leverages their current workflow, at least more than a lot of other solutions out there. Something we haven't talked about yet, which I think, people would be interested in is how does direct play with all the other things that we hear talked about, the, EHR APIs, the FHIR, which has been on fire, as people have liked to say, right? The FHIR implementations, where's Direct's place in this? Will it be replaced by FHIR? How is all of this going to play out from your perspective? Julie, go ahead.
So we've talked about this a little bit, but just to kind of reiterate, you receive a direct message because someone sends it to you. So you have access to that health information because it's pushed to you or you push it to someone else. And that's a model that we understand in the same way that we understand email and the way we use email today. FHIR and other APIs are a query-based protocol. So I pull data that I have access to from a FHIR resource or from another API. And there are really use cases for both things for different reasons. And there are likely combinations of the two that will develop into applications as well.
Yeah, and I know folks are going to say, well, FHIR, you can, since it's built on HTTP, you can't actually do posts, which is correct. It's not query only.
Right.
If you think about the way FHIR works, it's really an endpoint to endpoint. What I mean, it's a very discrete endpoint, almost a peer-to-peer type thing. When you're talking to an HTTP server trying to execute a transaction, you're doing that to one single transaction. You have to know what the location of that transaction is. We're doing FHIR-based queries where you pretty much know what those endpoints are. You're trying to pull data from one point. You don't have an aggregator, that works well. But when you're trying to do the type of messaging we're talking about, where you may have multiple locations, multiple places. I think direct really becomes a much better complement. The technology is much more suited for doing this type of transport as opposed to doing something with fire. That's not to say longer term we may not have orchestration and other services on top of that may help facilitate that. But I'd say still for now, direct I don't see them being a competition. They're really complementary items that are going to solve different use cases.
Yeah, it may or may not be a good analogy, but you can think about building kind of the highways or the interstate systems to connect those known endpoints, as Greg was referring to, as being fire. But you still have a need for all the secondary roads, because in the end, we've got a kind of an any-to-any problem that we need to solve when we're really thinking about coordinating care in a community with everyone who touches the patient. Now, I'll even broaden it in one sense as well. We talk about providers as being representative of physicians, health systems, post-acute providers, but also more and more there are other providers that are touching patients in the continuum of care for population health. Nutritionists, other types of services. It could even be transportation, moving a patient in and out. And you want to be able to communicate, with all of those. So I think direct ultimately provides, an additional mechanism for an any type of communication that will still persist.
It seems like the challenge goes back to some of the trust things that, Greg talked about taking years and years to develop between the providers. Direct's been working on that for so many years, trying to create those trusting relationships and what's a trusted, secure way for us to communicate. And it's like, to use your road analogy, we're just starting to build those roads of trust in the fire one. It seems like that will take years to develop as well.
I don't think that's going to be the case. The good news is that the models for creating these trust relationships aren't really all that hard. The devil's in the details of what your policies are, but the model, specifically how we've done this with scalable trust and direct, parts of that, not all of it, because fire from a security perspective, I think is much more complicated than it is in direct. But the basic model of doing like EHR to EHR trust, which essentially a lot of use cases that you're doing, it is organization to organization transport. Even in the fire world, that same type of model that we've done inside of direct is almost completely movable over to the fire world. So getting all of these EHRs to communicate organization to organization, it's not really that far off to go do that. So the model exists. We know how to implement it. It's just defining what those policies are. And even to some of that, to some extent there, we've already got a good model and start for that as well.
So for this last 5 minutes, before we open up for questions from those that are watching live, let's take this really practical. Let's say you're a hospital CIO, or you're a small practice, or you're a patient, right? I mean, there's kind of those three levels: a hospital, a smaller practice, or a patient. What should they know about direct, and what should they be doing today to benefit from direct? Let's just go around the circle. Greg, you want to start?
Yeah, so if I took myself from like a hospital CIO, I'd really be asking myself how I can better leverage this technology to remove your dependency on doing phone, fax, and paper. Keep in mind, it really is growing. We hit on this earlier. I've seen some metrics just over the last couple of years. It's a J curve. You look at the number of messages going out, it really starts from almost like 200 and some thousand up to maybe 55 million. I think that's what the numbers are. So, I mean, it's really happening. Now, a lot of folks are saying they're having issues finding people to exchange with, but that's going to change, and that's a whole nother topic. And like I said, from a small practice perspective, I had mentioned if you're doing a lot of referrals and exchanges with these bigger organizations, they have direct. So now you have this capability of getting that information back and forth, and I really see that being better for their business.
And do you think they should use direct for their internal? I mean, there's so many hospital systems are buying up practices. Is it practical for them to use it internally, or should most of the focus be with external, or do you see both happening?
I actually do see both happening. I mean, if you're doing internal, it depends on what you call internal. But
Depends on if you have 3 EHR or if you have one.
Yeah, so if you've got something like 3 EHRs in there, I mean, direct could definitely make it easy of moving that information back and forth. It's just another option for interoperability of moving data around.
Interesting, but it sounds like long term it's better for disparate parties where you don't, you're not headed towards the integrated EHR. Julie, any takes on, what would you offer the small practice, that wants to benefit from it, or even the patient?
Well, I think any of those users potentially probably have access to direct through their EHR already. If they don't, or if the use case is different from what they want to do with direct, they might consider adding webmail capability if they don't already have it, or thinking about creative ways to get counterparties that they need to exchange with enabled via webmail to make those connections happen where they aren't already enabled. There are some organizations that are buying direct even though they aren't required to use it for meaningful use because they want to take advantage of that electronic data set.
I was trying to think. I don't know any of the major EHR vendors that aren't doing direct in some form or fashion. Sometimes they pass on the cost to the practice. Some of them offer it free, but I think pretty much all of them have that opportunity if they want to go and try it out. In fact, I know some that are, I've been to user conferences where they literally are saying, go here and sign up for your direct address, and other ones that are essentially, I wouldn't say forcing, but they're pushing really hard for every one of their providers to have direct addresses. So it seems like that's the best option for most small practices is go to their EHR vendor for the direct address. Is that fair?
That's right, unless they don't offer it. I mean, but like you said, all of the large ones pretty much do. There are some small ones that are still adding it in, though.
Well, yeah, we'll see how those small players end up long term. Mark, what do you think? How could they leverage direct?
Yeah, I would just add a couple of thoughts. At the CIO level, the hospital level, I would encourage them to take advantage of this, to always make it a practice to send follow-ups on admits, discharges, ED presentations, to the patient's primary care physician or other providers that are known to them, and that would actually encourage the two-way exchange of information. There's times when they don't have information, but that's needed in the context of an inpatient admission, and that could be provided really with via direct message and CCD exchange. For the small practice, I would say, here is a chance really to get in and begin to do a better job coordinating care for your patients, meet compliance requirements for meaningful use and chronic care management. We happen to have taken an approach, at Infina Connect that makes it easy to get to those things and really to connect to any provider at any venue of care. And then lastly, on the patient side, there's still kind of a demand that has to be, kind of promoted, to get providers to respond. And I would just encourage patients to continue to ask for access to blue button capability, access for them to have access to their records so that they've got, more influence and control over it. I think that will happen over time. It's just a question of, can we make it happen faster?
Interesting. That's two really good points as far as how do practices prepare for value-based reimbursement. This might be an interesting first step. And, going back to something I think Farzad tried to push, which is if enough patients start asking for their records, then the doctors will need to make that a feature. Mm-hmm. Great suggestion. Well, I want to thank each of you for participating in this interview. Once again, it was Julie Maas, founder and CEO of EMR Direct, Greg Meyer, distinguished engineer at Cerner, and Mark Hefner, CEO of Infina Connect. Thank you so much, guys, for joining Healthcare Scene. You can find all our videos at healthcarescene.com, where we post them, and see our network of content on healthcare IT topics. And we'll see you next time at our next video interview. Thank you so much.
You bet.
Thank you.